Hello and welcome to the Epilepsy Foundation of Minnesota. We here at the foundation believe that it's important for all of our staff members, no matter their role, to be able to recognize and respond to the various seizures and have a little bit of basic knowledge about epilepsy. This presentation will serve as that base for you. One thing we want to start about and talk a little bit is about just some epilepsy facts and some epilepsy basic information. We know that epilepsy has a lot of myths and misconceptions that are attached to it. This really comes from epilepsy being around for centuries and centuries. We know that it is documented way back to Julius Caesar and to other people in history. So through that time, a lot of misconceptions and a lot of the myths have come. We know that epilepsy is not contagious, it's not a mental illness, and it's not a mental impairment. But what epilepsy is it is a neurological disorder, and it really is the tendency to have reoccurring seizures. And those seizures are also unprovoked. So it means that something else in the body is not provoking those seizures from happening, but that a person is having two or more reoccurring seizures that are coming from the brain. We know people can have seizures for hundreds and hundreds of different reasons. It could be that they have diabetes. It could be that they have a really high fever. It could be that they're having a medication side effect. And not always are those seizures considered epilepsy because they have to be coming from the brain. And that's also where the unprovoked portion comes in. You also may hear or see the term seizure disorder, and they do mean exactly the same thing, so they can be used interchangeable. We know some physicians only use the word epilepsy, and we know some physicians that only use the word seizure disorder. On this slide, we just have some information about how prevalent epilepsy is. One of the big statistics that we use a lot is that 1 in 26 people would develop epilepsy at some point in their life. And even below that, we know 1 in 10 people will have a single seizure for any reason at any point in their life. So epilepsy is much more prevalent than I think we hear about some of the other conditions that are less common. So what's actually happening to the brain during a seizure? In our brain, as you can kind of see on the picture, we have all of these different pathways through our brain. I always like to think of them as kind of highways. And along those pathways and highways, we have neurons that travel. And the neurons, there's hundreds and hundreds of neurons, and all of those neurons carry an electrical charge. And as those neurons move from bunch to bunch and move around, that is what sends the messages to our body that helps us walk and talk and eat. And everything we do is because of the messaging that the neurons are sending to the rest of the body. And when a group of neurons misfires or has a discharge of electrical activity when it's not supposed to, is when a person has a seizure. So that misfiring could happen in one area of the brain, or it could be happening across the whole brain on both hemispheres. And it really is all about where is that misfiring happening of how the seizure looks and how it's presenting itself in the body. As far as what causes epilepsy, I think one of the biggest and most frustrating things for this is that, as you can see, according to the pie chart, almost 70% of people, the cause is unknown. We're still learning so much about the brain and so much about epilepsy that specifically what causes it in every case is still a huge area. As far as in the other roughly 30%, the number one known cause is head trauma. As you can imagine, any damage to the brain could definitely lead to some sustaining trauma or sustaining issues. There also could be a stroke. There could be a brain tumor. There could be an infection like encephalitis or meningitis. They could possibly have some sort of autoimmune disorder. Really kind of anything that could get in there and damage part of the brain. As far as possible seizure triggers. The thing with epilepsy is that it is very individualized. So it's very different for every single person. You're never going to meet two people that have the same type of seizures, the same type of treatment options, the same type of behaviors. It's very different. And the same is true with seizure triggers. Some people know if they don't get enough sleep at night, if they don't get that exact 8 hours of sleep, that it'll trigger seizures for them the next day. Other people may document for years and years, and they're never able to find a specific trigger for their seizures. Up here I have a list of some of the more common triggers. Hands down, the number one known cause is medication, failure to take medication. And we like to call this is medicine compliance. So making sure that people are taking this, their medication, the same dose at the same time every day. It's really, really important to make sure, as part of a self-management of this condition, to make sure that they're complying with their medicine. Some of the other things are really just basic lifestyle stuff, getting enough sleep, staying hydrated, eating well, managing stress and anxiety. And the other stuff on this list is also can be big correlations. Photosensitivity, which is like strobe lights, or sometimes it can be movies or video games. It's really not quite as common. About 2% of people with epilepsy are actually photosensitive, and a lot of people are really sensitive to more of the natural light. So maybe the light coming through trees or coming through buildings. We also know there's a big correlation with hormones in the body. So this can be during those teenage years, and again later in life when we know that there's huge fluctuations in the hormones in the body. And then there's also a correlation for women every month during their menstrual cycle and how it's related to seizure activity. As far as seizure classification, there are actually 40 different seizure types out there, but they start first by just classifying them. So they like to classify as far as where is that misfiring happening. And then from underneath there is kind of how they go into more of the specific seizure names. So the first part is that a focal or partial seizure. And that means that misfiring is happening in just one part of the brain. And a person may or may not have change in their awareness. And it really all depends on where that misfiring is happening of what the seizure would look like. The other seizure type or classification is the generalized seizure. And so this means that the whole brain is involved. It means there's misfiring on both sides of the hemisphere. And this it could look like there's convulsions, sometimes it's staring, could be muscle spasms, and we're going to go into some of the more common epilepsy or seizure types kind of following this. I don't have, during this presentation, there aren't any clips or kind of any videos to show a good visual of the different seizure types, but on our website, under the resource tab, there is a short video. It's about 11 minutes long that kind of goes through all the different seizure types, the common seizure types, and what they look like if you would like a visual. So the first seizure type I'm going to talk about, I'm really going to focus on the four most common types. The first kind I'm going to talk about is the focal seizure without change in awareness, or sometimes called the simple partial seizure. The focal seizures without change in awareness, these people have no loss of consciousness and no loss of awareness. So they could be having a conversation with you and you would have no clue that they are having a seizure. Sometimes it is that they do have uncontrollable movements. Maybe just their hand is shaking, maybe just their leg is shaking. Other times it could be that a sense is maybe affected. So it might be that they smell something, they might taste something, they might hear something, they might have kind of a strange sensation. For example, there is a woman, and for her seizures, for her simple partial seizures, it used to be that sometimes she would hear ringing bells. Other times she would look out and hallucinate that people didn't have arms. And other times she would just get this really strong sense of deja vu for maybe just a minute or two. She never had any other seizure types. And she never had any loss of consciousness. So for her, it was just finding a way to kind of manage those kind of the different ways that her seizure showed itself. Some people may have this kind of seizure as an aura, so it may be a sign to let them know they're going to have a larger seizure. For example, another woman, she sees this bright, bright rainbow in her whole line of vision, and then she knows in about 45 minutes she's going to have a tonic-clonic seizure. So she knows to kind of go get somewhere safe, or maybe just go and make sure that she's sitting down. But not everyone has that aura or that simple partial seizure beforehand. Sometimes it might even just be 5 or 10 seconds before the seizure starts. As far as how to respond, if you see someone having a simple partial or they let you know that they're having a seizure, this kind of seizure, really all that you need to do as a bystander is just reassure them and make sure that there's nothing that they need from you. The next seizure type is the focal seizure with change in awareness, or the complex partial seizure. So this is actually the most common seizure type. Very often people think about the tonic-clonic seizure or the grand mal, and they think of that as the most common seizure type, but the complex partial seizure happens in about 60% of people with epilepsy. The thing with this seizure is that it can be really challenging to identify because it might look like a lot of other things. It could look like a person is intoxicated. It could look like they're over-medicated, because what happens is their awareness is 100% gone, but their consciousness is just altered. So they still might be able to stand. They still might be able to kind of walk around. Sometimes people have this repetitive, purposeless movement. It might be that maybe they are wringing their arm. It might be that they're blinking their eyes, smacking their lips. I really think that a good way for a person to tell if they're in a complex partial seizure is to look at their eyes. You can tell that they're not able to focus, and it really kind of looks like they are zoned out and that they're not sure of what's going on. And if you go up to them and ask them a question, they're not going to be able to answer, and they're not going to be able to kind of be a part or be able to respond appropriately. So that's the other thing when we think about seizures, is that we tell people that you're always kind of looking for a pattern, is that seizures are going to follow a pattern, and they're going to look the same, relatively the same every time, because there's always going to kind of be that same pattern of behavior. So how to respond to a person that's having a complex partial seizure? Staying calm is, of course, always really important, because with you as a person that has some knowledge, not only can you help the individual, but you can help any other witnesses around that may or may not know what's happening. So it's really important for you to make sure that you're staying calm and letting other people know what's happening, and that you have the situation under control. Because the other thing is, we don't need to have 5, 6, 10, 20 people responding to a seizure. 1 or 2 people is appropriate and enough, and able to help the person so that when they do come out of their seizure, they're able to kind of get back into the swing of things. It's really important with the seizure types to track the time. This is a great thing to delegate off to someone else, or we do have a Seizure First Aid app that is really great, that as soon as you open that app, a timer starts. So that can be really useful in making sure that we know how long the seizure is lasting. With a complex partial seizure, you also don't want to restrain them. It may be that they're walking around, they may just be standing, or they may be sitting. It's really our natural tendency that we want to keep the person safe. So maybe we're trying to put them in the corner, or maybe we're trying to sit them down if they're standing. But the brain is in such a basic mode. They don't know your intentions, so they don't know that you are trying to help them. They're just really thinking about keeping themselves safe. And so they may appear aggressive or agitated as you are trying to get in and control the situation. Really, you just kind of need to be nearby them and make sure that they're okay. And if they kind of do fall down, make sure that everything around them is safe, and that you gently have moved them away from any hazards. And of course, you want to make sure that you stay with them until they've gained some sort of full awareness. You'll be able to tell when the seizure is over with a complex partial, as that usually they're able to start kind of answering your questions. It still might take a little bit of time, but you're able to see that their eyes have kind of come back, and that they are at least out of their seizure, and that it may still take another few minutes, or sometimes it can take a few hours for people to kind of get back to feeling 100%. So those were the two partial seizures, and now I'm going to talk about two generalized seizures. So the first one is the absence seizure, used to be called the petit or petit mal. In 1989, the CDC changed the names from petit mal and grand mal to what we call them now. And really the big thing is moving away from the negative connotations. So petit mal stands for small bad in French, and grand mal stands for big bad. So you can see why they did kind of move or change the names to much more of medical terms. So the word is really absence, but we do pronounce it absence, which is the French word for absence. And what's great about kind of that title is that it really is just a brief absence. We're talking similar to a light switch, on and off. It can be 5-10 seconds long, very, very brief. But because it's a generalized seizure, the whole brain is affected and the whole body is affected. So even though they don't have convulsions or they don't lose muscle control and fall down, they have no processing of information coming in and no processing of information going out. And there is no recovery period with this one either. They're able to come right back and get right back into a conversation or get right back into whatever it was that they were doing. So with the absence seizure, it can be really tough to notice because it looks like daydreaming or it looks like zoning out. And lots of times people miss them. But if you do happen to notice one, really the best thing is just to document or just kind of to let the individual know what you observed and kind of what you saw. So the last kind I'm going to talk about is the generalized tonic-clonic, or the GTC, or the grand mal. Again, not the most common seizure type, but probably one of the most scariest to see because there is that complete loss of consciousness and complete loss of awareness. It usually starts with maybe some sort of sound as the air is being pressed out of the diaphragm. It might be a yell, it might be more of a guttural sound, and then they'll go into the tonic phase, and that's where their muscles will get really, really tight, and they'll usually kind of fall down and kind of lose some of that muscle control, and that might be 15-30 seconds, and then they'll go into the clonic phase, which is the convulsions and the shaking portion. There are some things that might happen during a tonic-clonic that seem really life-threatening. They might have a really irregular breathing pattern. They might be vomiting. They might have loss of their bladder or bowel. They might also have bluing around their lips or kind of around some of their extremities. And this is really just a part of the seizure. The breathing thing, it could be that it is really slow or it could be erratic, but as the seizure ends, the breathing comes back to normal, as well as like coloring or kind of any of that thing. And most importantly, they are going to last less than 5 minutes. Most of them are lasting 2 to 3 minutes. So as far as how to respond if you are seeing someone have a tonic-clonic seizure, I really think about the three most basic things. You want to turn them on their side, protect their head, and don't put anything in their mouth. So turning them on their side is really helping to keep that airway open. And that is really the most important thing to remember during any seizure type, especially if they have a loss of consciousness, is that we're trying to keep that airway open. So if there was any vomiting and there might be a lot of excess saliva because they're not able to swallow, getting them on their side is going to help naturally keep that airway open. So it's really similar to the rescue position that we learn in first aid. The next thing is that you want to protect their head. So if you have a pillow or anything around you soft, sometimes you can even just put a sweater or a sweatshirt, or you can even just use your hands to put underneath their head just to make sure that they're not having any more kind of damage to their head during the seizure. And the third thing is to not put anything in their mouth. So this used to be best practice that we would say, put something in their mouth so they don't swallow their tongue. A person, your tongue is attached, so you're not able to swallow it. It may go back and block the airway. So that's why it's really important to try and get them on their side so that we can keep that airway open. And also, it can be really dangerous for you as the responder because sometimes they might have lockjaw or they might bite the thing off and swallow it. So all you really need to remember is turn them on their side and protect their head. And of course, we want that all important to track the time. So again, if you can delegate that off to someone, or if you have an app or your phone or some way to be able to notice the time for that. And as the seizure ends, we also want to make sure that we're really just kind of helping readjust them and reassure them and kind of get back. It really could take just a couple minutes, or for some people it takes even longer. And we really just kind of want to make sure that they're feeling okay and realize that they might need a little time to get back to their 100%. Let's go on to talking about when to call 911. Most seizures are not medical emergencies. Most of the time, they will end on their own. You're able to just provide some basic, simple response, and the person will be able to kind of go on after the seizure has ended. Sometimes there may be a need for further medical assistance, and we might need to call 911. And of course, that decision is always yours, and make sure that you're feeling comfortable. Sometimes it just may be that that the situation that's happening, it feels that it's escalated and it's out of control. Absolutely make that call if you need to, but not all seizures are medical emergencies. As you can see by the list there, kind of reasons that you might want to is if they're injured. We don't want to provide first aid during the seizure, but after the seizure, you might need to provide some basic first aid, and some things might require a call to 911. If the person has diabetes or is pregnant or has some other maybe really severe condition, chronic condition that it might have an effect on. If that normal breathing doesn't come back, or if their breathing stops, if it's a first-time seizure that you know of, which could definitely happen in a public place. You could be somewhere and know nothing about the individual, and so you may need to call 911. They might not have a medical bracelet identifying that they have epilepsy. If they have a seizure in water, there's just a lot of complications, so we say that it's always best to make sure to call 911. There are a lot of different treatment options out there. We're not going to go over them for this presentation, but hopefully we were able to kind of give you some great, just basic information and feel a little more comfortable about how to be able to respond to when you see a seizure. Just like any other first aid situation, the more information you know, the better you'll be able to respond. And as a staff member of the Epilepsy Foundation, we really hope that you're able to feel comfortable with some of that information. If you have any questions, please feel free to reach out to the education program manager or the human resource director, and we'll be happy to answer any of your questions and hopefully get you enough information. Thank you, and again, welcome to the Epilepsy Foundation of Minnesota.